Hi, my name is Rachel Marcus, and I'm an echocardiographer in Baltimore, Maryland, in the United States, and also, more importantly, the medical director of the Latin American Society of Chagas, which is a nonprofit where I work with Latin American immigrants to the metropolitan Washington, D.C. area who have Chagas disease. Today, I'm speaking about Chagas or sarcoid heart disease. So, why compare these two diseases? Well, they're really interestingly similar in a lot of different ways. First, and for me, most importantly, both of these illnesses, for sure in the United States, but I think worldwide, are under-recognized. And because they are illnesses that tend to occur in people who are impoverished or in minority groups, there are social justice issues around trying to raise awareness about these diseases. There are also many similarities in the clinical presentation, and the diagnosis really matters. So what are they? Well, they're both inflammatory cardiomyopathies. Chagas disease is an inflammatory cardiomyopathy caused by Trypanosoma cruzi infection, which leads to longstanding myocarditis and subsequent scarring. Sarcoidosis is a granulomatous infiltrative cardiomyopathy of unclear etiology that causes intermittent myocarditis and subsequent scarring. It's thought potentially to be an immunologic response to an antigenic trigger, although the trigger is unknown. So, what are the demographics of these diseases? Well, sarcoid affects the young. 70% of cases are between 25 and 60 years old, and the most common presentation is between 20 and 40. Sarcoid is found everywhere in the world, but more in certain subgroups: African Americans in the United States, Northern Europeans, and Japanese. The demographics of Chagas are slightly different, although it also affects the young adult in that it presents 15 to 30 years after index infection, which, as you know, is generally in childhood. It's mostly a disease of Latin Americans, but because of immigration, it's now worldwide and found in the United States as well as Europe, Japan, and Australia. It is also, though, a disease of the poor. What's the prevalence of Chagas disease? Well, as you know, the prevalence varies by country. Most recent data from Colombia suggest an overall seroprevalence of 2%, 3% in adults, and 1% in children. Of course, one of the problems with this data is that there's widespread underreporting or even no reporting at all of Chagas disease prevalence in many of the provinces. So this is really a best guess. The highest prevalence currently in the world is probably Bolivia, with rates of about 6 or 7%. In the United States, where I work, 300,000 individuals are estimated to have Chagas disease. Several studies looking at Chagas rates in the community and in primary care settings have shown rates between 1 and 4%. And where I work, it's 4%, although in the Bolivian immigrants, we see 22% of these patients having Chagas disease, or 22% of the individuals that we've done assays in. The prevalence of sarcoid is a little bit less well understood. Sarcoidosis overall, not cardiac sarcoid, is found in 5 to 10 cases per 100,000 people in whites in the United States and 35 to 40 in 100,000 in African Americans. Cardiac sarcoid affects 20 to 30% of sarcoid patients, but only 3 to 5% will have clinically apparent disease, and up to 25% of deaths from sarcoid are due to cardiac illness. Um, this is a really interesting similarity. If we're actually going to look at the histopathology of both of these illnesses, we'll find infiltrative cardiomyopathies with inflammatory cells. Chagas disease is on the left, and you'll see that these are the epimastogotes snuggled into a myocardial cell with dense lymphocytic infiltrate around it. Sarcoid, on the other hand, has granuloma with these lymphocytes around them as well. But Chagas disease can also have granuloma, so in some ways they'll look very similar on biopsy. In terms of the kinds of cytokines that are activated during this disease, I've circled in red those that appear for both illnesses. This is sarcoid and this is Chagas. We see interferon gamma and cytokines. We see immunoregulation with interleukin 10, regulatory T cells, and we see the same things up here in sarcoidosis. So there may be a similar final common pathway for the development of the fibrosis in these diseases. In terms of clinical features, they both affect the conduction system, and they're both profoundly arrhythmogenic. They cause right bundle branch block, heart block, and ventricular tachycardias, as well as bradyarrhythmias. They cause cardiomyopathies with regional wall motion abnormalities, and echo findings can range from normal to severe impairment of ventricular function. These are both bad diseases. Unfortunately, they're both associated with worse clinical courses than other cardiomyopathies to which they've been compared. Both are associated with lethal arrhythmias at less depressed ejection fractions and heart block at less depressed ejection fractions than what we usually think about and worry about in the cardiology clinic. Chagas disease increases the risk for stroke at a higher EF than in most other cardiomyopathies, and we're all very well in this aware in this audience of people who have normal ejection fractions, but say a focal apical aneurysm that predisposes them to the risk of catastrophic cerebral embolism. And what difference does it make? Why do we need to make this diagnosis? Well, I think that you all understand very well why you need to make the diagnosis of Chagas disease. Unfortunately, that's not true in the US, but it's also really important to make the diagnosis of sarcoid as well. Why? Aside from prognosis, the treatment is different. We are more likely to offer a defibrillator to a patient at a higher ejection fraction, particularly because we should be doing very aggressive investigations to see whether these patients have arrhythmogenic substrate when their EFs are maybe mildly depressed, or maybe if all they have is a wall motion abnormality. Immunosuppression is appropriate for sarcoidosis. And Chagas disease, because it's an infectious disease that can be passed by maternal fetal transmission, it's really important to make the diagnosis in a woman so that the children can be screened and other family members as well. And of course, we need to watch for reactivation with Chagas disease after transplantation. So when should you think about these diseases? Well, you should think about either one of them when a patient who's known to have the disease is sent for an echocardiogram to evaluate for cardiac involvement. We should think about it when we see a patient with right bundle branch block on their EKG, heart block, or ventricular tachycardia. And when you're reading an echo of a patient in whom the diagnosis has not been made and notice the findings suggestive of the disease. And this is also true if you are a cardiac imager looking at MRI scans, where you might see the findings suggestive of either Chagas or sarcoid in a patient who previously has not had that diagnosis. So let's talk about some of the imaging that we do. The first, of course, is the EKG, and that's in Chagas disease, as you know, because it's the main diagnostic criteria for chronic phase. Of course, we're looking for the findings that might show that there is fibrosis in the conduction system or scarring, and these would include the things that are listed here. I'll show you actually now a table from a paper that looked at 49 studies with about 32,000 patients in it and did a meta-analysis of the findings that might be more commonly associated with Chagas. And you can see them on this list here: left anterior fascicular block, PVCs, first degree AV block, AFib or flutter, bifascicular block, and right bundle branch block. Now, for most of the people that I talk to in the United States, I have to make it very clear to them that just because an EKG abnormality is not in this table, it does not mean that the patient does not have Chagas disease. It's just that these are the findings that are most associated with a diagnosis of Chagas disease. Now, you are probably well aware of these two papers. The first is a table from a Brazilian CHF clinic in which patients with Chagas disease in this column and other non-ischemic cardiomyopathies in this column were compared on the basis of their EKG findings. Here we see the marked predilection of bifascicular block in the patients who have Chagas, whereas bifascicular block was seen only in 5% of the patients with non-ischemic cardiomyopathy. The reverse is true for left bundle branch block, with only 10% of the Chagas patients having that, and 50% of the other non-ischemic cardiomyopathy patients as well. In this particular trial, AFib was equally common in both groups. This is from the Paradigm Heart Failure and the Atmosphere Heart Failure database, where we see very similar findings in that the right bundle branch block finding was much more common in the Chagasic patients relative to other non-ischemics and ischemic, and the left bundle branch block, the reverse was true. In this particular paper, though, the Chagasic and other non-ischemic cardiomyopathies had more AFib than the ischemic patients. So what about sarcoidosis? Well, this is a table from a paper that looked at clinical manifestations of cardiac sarcoid. And it's really important to note that patients with sarcoidosis alone, particularly if it's in the pulmonary disease that causes significant pulmonary hypertension, can have EKG changes simply based on the fact that they have RV pressure overload or RV volume overload if they have tricuspid regurgitation. But these are the findings that you see if somebody actually has left heart disease. So they'd be AV block, bundle branch blocks, SVT, VT, and sudden cardiac death. This is another very small study that did a comparison between patients with sarcoid and patients with idiopathic dilated cardiomyopathy. And they found very similar findings to some of the studies with Chagas disease. So the patients with sarcoid had a much higher prevalence of right bundle branch block than did the patients in the idiopathic dilated cardiomyopathy group. Left bundle branch block, I think, was not statistically significant, although you could see that there were, in fact, patients with left bundle in the idiopathic dilated cardiomyopathy group. And AFib was much more common in patients who had the idiopathic dilated cardiomyopathy, but third degree heart block was much more common in the patients with sarcoid. So what is the role of EKG in sarcoid? Well, it's not diagnostic of cardiac sarcoid, as we mentioned, but EKG abnormalities are strongly associated with cardiac involvement in that 13% of patients with abnormal EKGs who had sarcoidosis had evidence of cardiac sarcoid, and only 0.1% of patients with normal EKGs had actual evidence of cardiac involvement. I should say that this was not using MRI, this was using the Japanese diagnostic criteria, which we'll get to in a moment. So talking about other imaging modalities, we have the echocardiogram in Chagas. As we all know, it can be normal and indeterminate phase, at which point we feel that people are low risk for VT and for stroke. Patients can present with regional wall motion abnormalities, including the post-row-basal lesion, which we all know is the most typical, but elsewhere in the heart as well, although not typically the basal septum, which will be important in a moment. Apical aneurysms, of course, are the hallmark of Chagas disease, Chagas cardiomyopathy, with or without thrombosis. And of course, patients can have dilated cardiomyopathy, although what I always remind my trainees when I'm talking with them about Chagas is that these are often cardiomyopathies in which there's scar. So patients who look as if they might have an ischemic cardiomyopathy because of focally thinned walls or focal akinesis. And those are patients then, if they don't have coronary artery disease, where we really need to think very strongly about Chagas cardiomyopathy as the diagnosis. So what about the echo findings in sarcoid? Well, they're remarkably similar with one major exception. In patients with cardiac sarcoid, even with cardiac inflammation, can have normal echocardiogram. Major criteria include, however, basal septal thinning, which is not something that's very typical for Chagas disease. So if you see this, you might think more about sarcoid. Minor criteria, however, include the inferolateral akinesis and apical aneurysms, both of which we know are shared by Chagas disease. And dilated cardiomyopathies with scar are another finding that might suggest that sarcoidosis is present. One thing that I did want to mention, though, that is, I think, more unique to sarcoid than to Chagas disease is a presentation that's very similar to hypertrophic cardiomyopathy. To my knowledge, this is not something that Chagas disease does as well. So the diagnostic criteria for sarcoidosis that were devised by the Japanese Ministry of Health are really quite interesting because there's so much overlap between what would be considered to be a case definition for sarcoid that actually could be Chagas, including having two major criteria: advanced AV block and depressed LV function. Could be sarcoid, could be Chagas. And then one major criteria and two or more of the five minor criteria. Well, these are the five minor criteria, all of which that could be shared by Chagas disease. So using this Japanese Ministry of Health criteria, we would have a very hard time distinguishing between Chagas disease and sarcoid in your patient population in Colombia. So let's talk now a little bit more about the echo findings. One of the things I wanted to mention that is having a normal echo does not necessarily mean that the patient does not have either inflammation or scar in either disease, and that strain can play a role as a marker of myocardial involvement in both disease processes. These are two examples, one from a patient with sarcoid up top, one with a patient with Chagas disease on the bottom, in which there was gadolinium uptake by MRI. In the sarcoid example, there was also gallium uptake, and you can see focal strain abnormality both in the sarcoid patient and in the Chagas patient, in patients who had normal ejection fractions. So in terms of regional wall motion abnormalities that we might see, this is a patient with sarcoidosis. Well, it looks very much to me like it could be a patient with Chagas disease. They have basal inferolateral akinesis. Next, we'll look at a patient who has a very unusual focal abnormality here in the basal septum. This is not something that I've ever seen in a Chagas patient, and it certainly brings more to mind sarcoidosis. This is a patient with sarcoid who, if you look at the apex very carefully, I'm sorry it's not imaged very well, has focal apical akinesis. Now, this is something that I might expect to see in a Chagas patient as well. This is a patient who has pulmonary hypertension from sarcoid. You can see that there's septal shift to the left and the right ventricle is very large. This is something that I would not expect to see from a patient with Chagas disease. And the tricuspid regurgitation in this patient is also quite significant in the absence of significant left heart disease. This is a patient who suffered cardiac arrest. You can see that there's global ventricular dysfunction as well as abnormal septal motion. Interestingly enough, 9 days later, the patient had re-imaging, and you can see that LV function has improved significantly. I do like to caution people that if a patient has come in with cardiac arrest, But they should re-image the patient after a chance for the stunning has resolved in order to be able to get a good baseline assessment of what their LV function is. This is the apex of somebody with Chagas disease. As you can see, there's a very large apical thrombus in this patient. And this is an example that I like to show people to remind us of how difficult the apex can be to visualize in both of these diseases. And particularly in a patient with stroke, we might want to be very careful about giving contrast injection to be able to make sure that we've seen the apex well. This is a young man who had a stroke. This is a young man who presented with palpitations, had bifascicular block, immigrant from El Salvador, and this was his initial echo. After he returned with a massive MCA infarct, he was found to have this focal apical abnormality. This is a patient who, if you looked at their echo, you might think that they had an ischemic cardiomyopathy with ischemic MR. Could be from either Chagas or from sarcoid. In this particular patient, the diagnosis was Chagas disease. And this, and finally, is a patient with a dilated cardiomyopathy with wall motion abnormality that could be the hallmark of either disease. I'm not very expert in MRI, but this is certainly something that we need to think about when we see focal gadolinium uptake, particularly at the apex. And here's another example. So in sum, what I'd like to say is that Chagas and sarcoid have many overlapping manifestations. Their EKG abnormalities, the Brady and tachyarrhythmias, and the wall motion abnormalities that can occur. Both are more common than we think, and that making the diagnosis really matters in that defibrillators are important in these patients at EFs that we usually don't worry about. The treatment ramifications and the prognosis is very bad. Thank you very much. I appreciate your letting me have this time to share this with you.